Welcome. I am Tammy Dangerfield. I'm a physical therapist at the University of Utah Pain Management Center. So I don't specifically and formally specialize in headaches, but I have a strong interest and I treat headache a lot. So I got off of where I needed to be. Okay. Just want to make sure I could see everybody, but so I'm going to talk about a couple of different classifications of headache, actually. Specifically, I'm going to talk about myofascial pain, and that's what I'm going to spend most of the time on. And there's kind of some overlap with myofascial pain and myofascial headaches versus tension type headaches or cervicogenic headaches. So it's going to address all of those on some level. Here we go. So we're going to talk specifically about what myofascial pain is and kind of understand what muscle dysfunction is and how that contributes to pain and headache specifically. And then we're going to talk specifically about trigger points and talk about how you could go about releasing trigger points on your own. So when we come to headache types and headache classifications, one really common one of the most common ones that we see besides migraine is what's called a tension type headache. This is kind of the definition. They typically are thought of as bilateral location, consisting of kind of a pressure type or a tightening type quality, not the pulsating quality that we associate with migraine. They're associated with mild or moderate intensity and not aggravated by physical activity. Cervicogenic headaches are kind of a secondary type of headache, but they are thought to be due to pressure, pain, irritation of the structures in the neck. So more commonly thought of as kind of upper cervical or higher neck joints or nerves, but can also kind of include any of the structures of the neck contributing to headache. As you may have learned or heard or been taught in some of these classes, there is a lot of overlap of symptoms. I think most practitioners who treat headaches think of it a little bit more of a spectrum of symptoms. It's not always easy to classify headaches into one type or another. Or there just might be more than one type of headache occurring. So today we're going to kind of associate that with what is called myofascial pain. Myofascial pain and myofascial headaches really kind of overlap both of those types of diagnoses. Myofascial pain limits movement. It can limit joint movement. It can put extra pressure on discs. It can put extra pressure on the nerves, actually, and the blood vessels in the neck. And it also has its own specific referral patterns. So again, a little bit of overlap, but it certainly can affect any sort of cervicogenic headache and any sort of tension type headache. Myofascial tissue can cause also a significant amount of pain. And I think that's one of the things that people don't often recognize and maybe isn't quite captured in the headache classification symptom or syndromes is that even a tension type headache or even a myofascial headache or cervicogenic headache doesn't necessarily tell you much about the intensity of the headache. So you can have pretty intense headaches that fall into the tension type category or the myofascial category. What that is, what a myofascial headache is, or what, let's even back up just a little bit. What myofascial pain is, because it occurs in other places in the body besides the head, myofascial pain is pain that is being generated from the muscles and the fascia. So, myo means muscle, fascia is connective tissue that runs throughout the body. You can almost think of it like a loosely knit sweater on the inside of the body. You can also think of it as kind of a spider web on the inside of the body. It's actually more of what it kind of looks and functions like. But that tissue is one continuous tissue throughout the body. It is really highly intertwined with muscle tissue. So when we talk about pain in these tissues, um, we talk about it in terms of muscle more often than not, because frankly, people understand muscles a lot better than they understand fascia, although we're starting to learn more and more about it. On to the next slide here. This is oops, kind of a nice picture. There we go. Sorry, there's a little lag in these of how myofascial tissue is organized. So this is just kind of a generic muscle. You can see here is a bone, and where the muscle attaches to the bone is what we call a tendon. And muscle is comprised of ever decreasing sizes of fibers that typically run in parallel. There are different shapes of muscles, but most often they kind of run in parallel like this. So if we start at this very smallest part of the muscle structure, the very smallest fibers we call myofibrils. A collection of those together is a muscle fiber. A collection of those together we call a fascicle, and a collection of those together we call a muscle. You can see in the schematic, the pink would kind of represent that muscle tissue. But around every one of these little tiny parts of the muscle is kind of a whitish looking uh, picture here. That is representing the fascia. So that's representing that connective tissue that really is just highly intertwined throughout the muscle. If you look at some of these bigger structures, it's a little easier to see the colors and the organization, but the fascia is running around and between every one of these little fibers. Within the fascia, you can see the red and the blue and the yellow representation here are uh, veins, arteries, and nerves. So this tissue actually is kind of the pathway or the highway where our blood vessels and our nerves run. So it affects those, it affects the muscles themselves. And then where they attach to bone, they attach any sort of bony movement. So they can also certainly affect joints. So we define myofascial pain as the presence of active trigger points in the muscles. There are lots of terms that get used kind of interchangeably out in the world there, but this is how it's defined. This is defined and kind of clarified by work that was actually done in the 50s and 60s by Simons and Travell. That might be something that people have heard of. It probably isn't, but this is the classification that we are working with, and that seems to have the best evidence and also a very extensive body of work that's really helpful to define and treat these. So a trigger point, people commonly call them knots. It's probably as good a description as anything. It is a shortened, kind of tight band of tissue within the muscle. So it comprises muscle fibers and fascia. And it's almost like part of the muscle that's in spasm all of the time is probably the best way to describe it that I know of. That's pretty easy to understand for most people. There's some controversy. There are some people that may define some of these things a little bit differently, but based on the work of Simons and Travell, this really holds true across all different types of kind of pain generating muscle dysfunction. So the way they would define it, if my fingers are muscle fibers, normally your muscle fibers overlap in a position where there's a little overlap at rest. When a muscle shortens, the fibers glide over one another, and when a muscle lengthens, the fibers glide out. So that ability for those muscle fibers to glide over themselves is how muscles work. It's how they move us and support our skeleton and do all of the things that muscles are supposed to do. When these tissues get overloaded for any reason, and there are many, many things that can overload these tissues, but when they get overloaded for any reason, they'll have a tendency to shorten and get kind of stuck in that shortened position. And that's what we would call a trigger point. Working with these a lot, I would say more often than not, it feels more like a band in the tissue rather than just a point. But that's what they're called, as trigger points. And they're actually classified into two different types. So there's latent trigger points, or kind of turned off trigger points. These are parts of the tissue, again, that are shortened and kind of stuck there and not moving normally. When you have a latent trigger point, they're generally not causing pain, but they do limit motion. Those trigger points don't move. So when someone attempts to move a muscle with trigger points in it, they move everything around the trigger point. And the trigger point, until you do the right things for it, stays pretty solid. It really doesn't glide and move normally. So that restricts motion. It also effectively causes weakness because parts of the muscle aren't moving very well. And when part of the muscle doesn't move, the rest of the muscle fatigues easier, and also you just don't get normal generation of force. Active trigger points are the same, structurally the same thing, but they've started to interact with the nervous system. So we kind of call these, again, active or maybe turned on trigger points. These trigger points, in addition to limiting movement and causing weakness, can start to generate quite a bit of pain, even at rest, even when the muscle isn't doing anything. So that's how we would classify it. When a person has what we would call myofascial pain or myofascial pain syndrome, they've got active trigger points in their muscles. The way we know we're dealing with trigger points is there is a palpable taut band in the muscle. Sometimes people can identify this on their own. Sometimes it's hard to identify on their own. But if you're dealing with someone who has some skill and experience working with myofascial tissue, they'll be able to feel those bands in the muscle and fascia. They are tender to touch. And one of the really characteristic things about active trigger points is they can have referred symptoms. And that just means that you're feeling pain or other symptoms in a distribution that's not at the location of the trigger point, but is provoked by that trigger point. So referred symptoms can be pain. That's the most common thing we see. They can also be tenderness in the distribution of the referral pattern. They can also be autonomic symptoms like numbness, sweating, goosebumps, some kind of symptoms that don't seem like they should be coming from muscles, but they really can generate a lot of these types of symptoms as well. The other way you know you're dealing with a trigger point is when you insert a needle into it, you get a local twitch response. So the muscle will actually twitch really strongly when you insert a needle into that restricted tissue. So I'm going to go through and show some of these common referral patterns. Some of these might look really familiar to some people that are looking at this. This is not an exhaustive list. I'm showing most of the pain generators that affect headache. But myofascial pain can happen anywhere in the body. These are some of the most common ones that we see. So trigger points in this muscle here, this is called the sternocleidomastoid. And it's a muscle that runs from the kind of behind the ear on the base of the skull forward toward the front of the collarbone. There's a superficial and a deep layer. This picture only shows the more superficial layer. The shading shows the referral patterns for these. So the darker the red, the more common that referral pattern is. The lighter red, sorry, somehow I got that to move forward. The lighter red is still a referral pattern for those trigger points. It's just less common. So in this muscle here, trigger points along these sternocleidomastoid can refer to the back of the head. It's very, very common. Also kind of around the eye, forehead, jaw, face. People often describe headache that feels very much like a sinus headache, but have had their sinuses checked and sinuses are fine and clear. So that's a really big one. The upper trapezius is also a really big one. This kind of classic ram's horn distribution of pain often comes from trigger points in this upper trapezius muscle. This one can also go into the jaw. I would say more often than not, the most common thing people feel is this kind of temple headache and pain in the side of the neck. Some other pretty common ones, this muscle in the back of the neck here can refer right to the top of the head. The muscles in the base of the skull, we call these suboccipital muscles, tend to cause that band-like pain, that band-like distribution of pain around the head. Some of these other neck muscles can really cause some symptoms that can sometimes mimic migraine or are also associated with migraine. So pain right kind of behind the eye, pain right at the base of the neck and shoulder. Some other kind of temple and kind of band-like distribution of pain can come from just a different muscle. These are all muscles that run along up into the neck. Um, and this one is a little bit different location than some of the others that we looked at. Another muscle that is got some kind of it has some interesting referral patterns, which is the distribution of pain in the teeth. But this temporalis muscle runs on the side of the head here. You can have trigger points in this muscle. Mostly the referral for these is kind of around where they are, but also you can get specific teeth hurting from trigger points in the temporalis. And again, if this is happening when we see people and treat these conditions, often they've been to the dentist. The dentist is tell them they can't find anything going on with the teeth. And sure enough, we treat these trigger points and their tooth pain goes away. Okay, so those are some of the most common ones. I will say, as a person who treats these a lot, and I think one of the things that is important to remember is very often people have several of these trigger points. It's rare that someone would just have one or two of these trigger points and one or two of these referral patterns. So if someone has a lot of these trigger points, it can feel like just the whole head or the whole neck. It can kind of become a bigger presentation than just one of these singularly. It's also really important to know that trigger points in the muscles can change. They can go from being not present to being present, but being kind of turned off or latent to being active. Uh, one of the tricky things about treating these is that muscles respond to the forces that are put on them every day. And we're sometimes dealing with a moving target when we're treating myofascial pain. So knowing these referral patterns and kind of knowing what it can be certainly is important, but also knowing that it can vary and it can change. Another really important feature that's kind of the second bullet point here is that myofascial pain really commonly does accompany other pain problems. One of the things that tends to really overload muscles is chronic tension or kind of chronic guarding, and that happens with a lot of pain conditions. So you can have arthritis pain or joint pain and myofascial pain, both of which can contribute to headache. You can have nerve pain and myofascial pain, both of which can contribute to headache. So I guess the moral of the story is headaches and pain in general tend to be pretty complicated. There's often more than one thing going on, and being able to identify all of the features can be really helpful in managing these symptoms. Um, just another way to maybe think about this is that trigger points can persist long after some other injury or problem has healed or been treated. Muscles, we tend to say muscles learn, but really the patterns that we use our muscles for, we learn. We learn those patterns and we have a tendency to move in patterns. We don't necessarily relearn movement without some intention behind that. So sometimes we learn patterns that are very inefficient and uncomfortable. So ultimately, from a big picture standpoint, we want to retrain the muscles to move normally. So we want to restore normal movement within the myofascial tissue. We really kind of have to start with doing what we call releasing the trigger points. Um, and we're going to talk a whole lot about that and practice it. But the idea being that if you are trying to use movement, if you're trying to stretch or strengthen or do range of motion exercises and that trigger point is still there, you're kind of just training everything around it. And you may not be really affecting the trigger point tissue at all. And again, I would say most of the time, if people have trigger points, there's not just one, there's usually multiple in a region. So we want to release the trigger points first so that the tissue actually can move normally. Then we would progress to things like stretching, strengthening, range of motion exercises to kind of maintain that ability to move. So, what is releasing a trigger point? Um, it is some combination of a little bit of length of the tissue and then also a whole lot of relaxation of the tissue. One of the things that we really need to learn to do in order to release this myofascial tissue is find at least a relaxed breath and be able to kind of maintain that while you're working on it. I'm sorry, I'm going to see if I can get this to go forward. Oh, there we go. Um, so how much length is it's not a lot. It's really hard to quantify and say this is how much you lengthen it or you know there's no perfect formula for what that is, but we do want to open up that tissue. We want to restore a little bit of length and just get some space in there so that you can actually get good blood flow. You want to be able to get good waste product removal. One of the reasons we really think that these trigger points cause so much pain is they almost choke off their own blood supply. So all those little nerve endings in the muscle tissue, if they're not getting enough oxygen, they tend to get really irritable and what we call sensitized. And that just means that if it used to take this much stimulation to set off a pain signal, maybe now it takes this much stimulation to set off a pain signal. So we need to restore a little bit of length there, but it's not as much as you think. It's really kind of going from pathologically tight to a normal resting length. So you don't have to stretch the crud out of them. I think people try to do that a lot of times, and typically it just takes a lot less than you think. So, that being said, this this tutorial is not to, we're not going to spend a lot of time on the relaxation component, but certainly learning relaxation techniques, diaphragmatic breathing. These are also things that we really use to help release trigger points. So we can release them a couple different ways. There are multiple massage type techniques that can help release trigger points. Um, there's stroking, there's pressure, there's tools people use, there's cupping. There are lots of techniques, and none of them are wrong. A lot of them can really help release this tissue. A lot of them require a lot of skill to do well. So being able to use massage and some of those tools is not always something that you have a lot of access to. But the one technique that you do have access to that people can learn to do for themselves is just using direct pressure. And if you do it right, it works. So that's the one we're going to focus on today is how to use direct pressure to release trigger points. The other one that we do use a lot in, at least in our practice, this varies from state to state as far as physical therapists being able to do this, but we sometimes stick a needle right in the trigger point and that can release it too. So none of those things are right or wrong, but we're going to focus on what you can do for yourself because you can release these yourself. So I'm going to demonstrate just with my hand pressure release on the upper trapezius, and I'd encourage you to try it along with me so you can see what this feels like. You can also use tools. You can use handheld massagers. There's a device called a Theracane, which is kind of a plastic cane, basically, and it has knobs on it to help you get pressure on trigger points that are kind of hard to reach on your own. And again, those are great tools. But the most important thing is the technique and doing that right. So I'm going to go through, I'm going to encourage you to do this with me, and I'm going to have everyone just kind of start feeling around the space where your neck and your shoulder come together. Most of us at least have a latent trigger point in this region. Um, if you're here and doing headache school, you might have some active trigger points in this region where they can become pretty painful and you can feel referred pain. So I'm going to just encourage you to go really gently at first as you do this. Again, difficult to quantify how much pressure to use, but I would say use the minimum amount you need to start just feeling if there's any tenderness in those areas. You can rub around. You can also kind of walk your fingers around. And sometimes that's a nice way to identify where you might find a spot that feels really tender. You may or may not be able to tell that it's tense or tighter, but when you're doing this on yourself, you'll be able to tell if it's tender. So kind of feel around, maybe walk your fingers around, find a spot that feels tender, more tender than the surrounding tissue, and put a little pressure on it. Again, my best guideline is just enough to know you're there, not so much that you can't breathe or relax. And then just take note. Notice how it feels right where you're pressing, and notice if you feel any referred pain. If we're doing this upper trap, the most common thing you're going to feel is kind of temple or kind of this ram's horn distribution. But notice what you do feel. Sorry, I lost my presentation, but we don't need it for this. You will probably feel tenderness right where you're at. If you do feel referred pain, don't panic. That's just what trigger points do. And then what we're going to do is do your darndest to keep your pressure the same. If you feel like you're meeting the criteria, it's enough to know you're there, but you can still breathe easily. And what will happen if you have the right amount of pressure is the tenderness in that spot will fade as you hold it. It takes a couple of minutes typically. So you have to be a little bit patient with these. And you have to be able to breathe and relax. So once you've noticed what it feels like, I'm going to have you just bring your focus away from the pain and to your breathing. So, a couple little tricks that can help you relax your breath. One is to just listen to the sound of your breath. Just let your breath be steady and easy, and maybe just hear that quiet sound that it makes. Another trick that can be helpful is to imagine that your windpipe goes all the way down to your belly. So it's like you've got a nice wide open tube from the back of your throat clear down to your abdomen. And what it might feel like if your breath was moving in and out of that long windpipe. Another thing you can pay attention to with your breathing is imagining that some of your breath is actually going into that muscle. So it sounds a little hokey sometimes to people, but it tends to work really well for a lot of people. So again, just focus on your breathing. Maybe focus on one of those sensations that seems to work the best for you. And then after you've been there for several breaths, notice that spot again and just see what's happening to the tenderness at that spot. Any referred pain that might be happening, let it do whatever it's going to do. That isn't going to be a reliable indicator of whether or not the trigger point is releasing. But notice what's happening at the trigger point and notice if the tenderness right there is better, same, or worse than when you started. And if it's better, if it's less tender, it's releasing. If the tenderness is gone and it just feels kind of like the pressure of your finger or the Theracane or whatever you're using, then it's released and you're done. And if it's getting close but not there, just give it a little more time. If you feel that tenderness getting more intense, you're pushing too hard and you need to back off and try it again. Again, it's really hard to quantify, but I would say if it does feel like that tenderness is getting worse, cut your pressure in half and try it again. And if it feels like it's almost there but not quite, then just come back to focusing on the breathing. Ideally, we really want to stay there long enough that you feel that tenderness completely fade away at that spot. So again, just kind of pick one of those breathing techniques, focus on your breath. Don't focus on the pain the whole time. It's really hard for them to release if you're focusing on the pain. But you do want to check in with it periodically and see what's happening. So I'm getting to the point now where that tenderness feels like it's just kind of the pressure of my fingers. I'm going to pull my fingers away. And once you think you're done, it really helps to just move the tissue a little. Move around, see how movement feels. It should feel like things are looser and it moves easier in that spot. Now, if that is one of your big trigger spots for headache, that can give you some really good pain relief. If that's just one of many spots, it'll probably give you a little bit of pain relief. Um, I would like to point out a couple of resources that I haven't listed specifically on the handouts, but I think they're really useful. One of them is a website that is called triggerpoints.net, and it is a handy roadmap to where you might find trigger points based on where you're hurting. So obviously we're here to talk about headaches. We went over a lot of the headache referral patterns, but this website shows those referral patterns for trigger points anywhere in the body. And it's nice because you can just click on where you hurt or where you feel the pain, and then it will show you where you might find trigger points associated with that pain. So if you're wondering if myofascial pain might be applying to other parts of your body, it's very possible and likely, especially if you have had a lot of pain for a long period of time. So you can use that as a reference point as to where do I look for trigger points based on where you're hurting. Another good resource is that Theracane. Um, there are all sorts of tools you can use, as mentioned, but for the ones that we're talking about here, kind of head, neck, maybe shoulder area, the Theracane is a nice, handy tool. It makes it a little easier on your hands. It's a little easier to relax when you have a tool that's kind of generating the pressure rather than you trying to have to generate a lot of pressure while you're doing trigger point releases. So I want to bring those up. Um, and I think really that is kind of the information that I wanted to go over. So if any other questions come up, I would love to answer those. This is a little bit more of a practice type of education, not just education. And I think that's where we get a lot of information, useful information for people to know how to utilize this information. Otherwise, I am going to sign off and again, just encourage you to maybe maybe just even ask questions about myofascial pain. Ask your doctor where you could get it addressed. Maybe seek out physical therapists that treat myofascial pain. Um, Even massage therapists, and there are other types of providers that treat myofascial pain. So none of them are right or wrong. I think just finding the best combination for you is the answer. And certainly anything you can do for yourself is the best. So you don't have to go to someone else to get it done. And hopefully you can at least get to that point where you can keep it released on your own. So thank you all for joining me and appreciate your questions, very thoughtful questions, and have a great evening.